Uh, Any changes to the agenda? I think we want to try to move Carrie and Grace, is that who it was?
Yep.
To the first on the agenda. And next I need approval of the minutes.
You'll probably get it back on Monday.
Okay, I need approval of the minutes.
I'll make a motion to approve the minutes.
Okay. Now, I don't need a second for that, right?
Nope, we're just gonna send them to
To
the
consent.
board.
Okay. Public comment. I don't think there's anybody from the public here. So no public comments. Financial statement. Okay, now we're gonna go to Carrie and Grace. Can we put Grace first? Because it's nice to have Carrie sitting here.
Grace is on her way over.
Oh,
She was
okay.
having technical issues, and so I'm pulling up her PowerPoint right now. So she's on her way. Hang on, I can't really see it.
I see you a little later.
It's not that we want you out of here, Carrie. It's just that all those numbers. I don't know where she gets them all from. Man.
Grace has a presentation here for this. So like I was saying, she was having some issues hearing everybody. So she's hightailing it over here to give her presentation.
Okay.
So if you want to move me
Yeah.
one down now from where you were originally attending, that would probably be okay. That way we're not wasting time.
Okay. Barb, I guess we can do the financial statement.
Oh, we're gonna
And then, well, yeah, he's tied up. Or you want to go, you don't want to go now?
No, Grace is actually presenting. I'm just here to answer any technical questions.
Oh, okay. Okay. So
Yeah.
should we go on down and then after we can break in? Okay. Oops.
Oh, we can do it. Sorry, guys.
Good morning.
Good morning.
Morning.
Thank you for waiting for me.
I need to share it there. All right, we're gonna share this, and Grace, I'll hand you the mouse so you can do it.
Okay.
And here.
Okay.
You see okay?
There we go.
There you go.
Move this over. Okay, hello to everyone.
Hey,
I'm
Grace.
Grace.
Good morning.
I'm the physical therapist and managing the rehab department right now. So I'm coming to you with a short deck and an explanation of the current electronic medical records we're using and why we need an upgrade. So just a quick overview. I'm going to go over what we're currently dealing with, some troubleshooting, a case example, how this affects department performance, and then a competitive comparison to the current software options, my preferred product, and our projected improvements with this product, some pricing and packaging, future offerings, and then next steps for all that. Looks like a lot, but I will speed through it. So this is TheraSys. This is what we're currently using. It was purchased over 15 years ago. Currently, we have some scheduling errors. So we'll, for example, put a patient scheduled on one of these time slots, and then the next day it's not there. And we're like, what happened to that? There's no tracing or evidence of appointments being added or removed. So that comes to be a big problem for us. This is an example of my schedule. I've blocked out the names for HIPAA compliancy. The way it looks is pretty usable. So it looks good, but it's just outdated. There's lots of glitches and time down. And then it's also a paper process, even though we have this hard software. That's not the right IT word for it, right? Even though we have this like on the computer program, we do have to chart on a completely different program that we have to sign into and then print that chart. So that's a patient note. So I have to print that chart and then make a folder, and we have a folder cabinet. And then at the end of the patient's plan of care, we have to break down those charts and run them over to the record office to be uploaded into CPSI. So there's genuinely a lot of manual labor involved in the software, and it's just not supported. We cannot upgrade it because it's just not available. And then it doesn't have really good reporting. So it's hard for me to be like, well, these are some things that aren't working that are showing up in our revenue. I can't have a really good insight as to what are the micro issues that are happening within the department to empower me to make more changes within the department. So I'll go over that more. But in general, this is a problem that needs to be changed. So here's just a case study. Mr. Don, he's referred to us by his pain specialist. He needs to be seen for 12 visits due to ongoing low back pain. And he also has prostate cancer and is currently seeing an oncologist in Bakersfield. His wife has Alzheimer's and he's her primary caregiver. And it's difficult for him to be away from her and to manage both of their appointments in Bakersfield. On top of that, now he's worried about COVID and he wants to reduce their time out of their home. So he calls us to schedule his first appointment, which we do. He shows up 2 days later for his appointment, and the appointment is not on the schedule. We don't know what happened. So me as the manager therapist, I will adjust my schedule to sneak him in. I'll do a short abbreviated evaluation with him. It's not great. It's not great patient care, but I want to just support the look of our community. So I will see him. And then he misses the following appointment because he's struggling to take care of his wife and their multiple appointments. He misses 2 additional appointments. And after that, due to our hospital policy, he's discharged. We've missed 3 appointments. So that's a loss of income for us. And he's not getting the care he needs. And now we're discharging him because it's been 4 weeks since he's been in. And so how does that look to his referring physician who sent him over for us to get him well? He was only seen 4 times. So it's not really good for developing our relationships here. So talking points, there were scheduling glitches. He needed appointment reminders. He's having a hard time. And we want to strengthen our physician referral relationships. I will also talk about telehealth because of COVID. We are in a COVID state here. So company performance, I did this tiny little graph here. The blue line, I don't know if you guys, I'm going to minimize this for a second. So the blue line is our no-shows. The green line is our cancellations. And this is since I've been in management here since July. Here is our anticipated revenue. Here's our actual revenue. So you can see in November, we had a big decline there. And luckily Chet helped me with understanding this. But one thing I can see right here is we had a lot more no-shows and cancellations in November. And that showed up for us fiscally. So this does have a direct correlation there that we can see. So I'll expand this again.
You don't need to.
This one, right? Yeah. Okay, so the next one. So industry overview. I looked at the top competitive softwares out there for rehab programs in hospital outpatient settings. And I narrowed it down to 3. Hence the stars, this is obviously the one I'm going to be going for. WebPT was a good contender. TheraOffice, the look of it is almost identical to TheraSyst, oddly enough. They're not related. So I think that this is going to be an easier transition for me in training the staff. And then the cost of this is just a little bit lower than this one. So, but in general, I came in with a very specific list of needs after evaluating what I was seeing happening, and this one is meeting all of our needs. So I chose TheraOffice. This is probably not enabled, I'm gonna guess. Oh no, here we go. So their whole thing is like, you can write a note in under a minute, which is way less than what we're doing right now because I have to open a second program and I have to log into that program. And then I have to write the chart. And then I have to open the exercises in another program and chart there. And then I print it and then I sign it and then I put it into the folder. So that's probably 6 minutes worth of work. And here I can do everything in the same program, one click in, one sign in under a minute. This is the way the schedule looks, which you can see is really similar to the one we're using right now. So we have this like miniature calendar over here, what therapists we're seeing here, and all of our options up here. The great thing is I can make a list of wait list. So if someone, Joe can only come in on Tuesdays at 7 a.m. Right now I'm booked, but if I have a cancellation, I'm going to try and fill that spot. That's going to be really great for our department. And then I'm also going to be able to click appointment reminders. And if a patient is canceled on the schedule, I will have evidence of who canceled that patient, when it was canceled, and why it was canceled. So there's tracing and auditing of everything happening on the schedule, which just makes us look better. And then over here, it's going to provide a lot more updated reports. So I'm going to be able to look at our how we're performing, and I'm going to say, okay, well, we had a deficit in November, hopefully not, but we did, and this is why. This is exactly why. And here is my plan to address that so that doesn't happen next month. So it's going to be pulling a lot more strategical reporting there. So projected improvements, appointment reminders have been shown just across the board to improve our revenue by 30%. So if people are just getting reminded of their appointments, it's just a lot of people up here, they have conditions that remembering their appointments is really tricky. So this is going to have less no-shows, less cancels, hopefully. It's integrated with CPI, which is important since CPI is our main hub of medical, our electronic medical software. The integrations are going to streamline things that we are manually doing in multiple departments. So billing, I chart my billing for my patients. And then at the end of the day, one of the rehab care providers has to type in manually each bill. And then that is uploaded into CPSI, and the billing department then processes it. When I do my charting, my billing is going to immediately be uploaded into CPSI. So there's going to be no errors happening there. It'll be automatic. The record department, all of the records from this software are going to be uploaded into CPSI. So we won't have to hand down our paper folder for them to literally scan and upload. And then what's that other one? I can't see. Administration. So, admin, they're going to be able to admit the patient through CPSI in the admin department, and then it will come from CPSI integrated down into our software so we can call them and schedule them. It's going to be really smooth. This is going to improve productivity for therapists. We want our skilled therapists, all of their time, or a high percentage of their time, should be billable. We don't want them doing things that are not supporting patient care. So that's going to help us cut down on the excess things that are taking time for our therapists. And then it's going to improve our community and patient satisfaction. This software also has a patient portal. So patients are going to be able to access like their intake forms. So they don't have to come here 15 minutes early and fill out these like paper forms when maybe they're already nervous to be here. They can do their forms ahead of time and just show up ready for their appointment. So yeah, like I said, paper intake is about 6 minutes for us, and it'll probably cut us down to 5 seconds, which I like. So here's the cost. So TheraOffice versus WebPT, I just wanted to show both of them, at least two. So the interfacing process, there's interfacing that needs to be done through CPSI, and there's interfacing programming that needs to be done through the program that we purchase. So for TheraOffice, they're quoting $6,000 to write this programming to upload the items we need into CPSI. WebPT is quoting $6,495. And then the monthly ongoing cost of upkeeping this software for TheraOffice is going to be $758.33, and WebPT would be $1,062. So there's a cost breakdown of the whole project here on the right. We need to be offering telehealth. We are losing a lot of clients and patients right now because they don't want to come in because of COVID. Their husband has COVID. They're scared of COVID. So all these things, lots of PT places have already made the full adjustment to telehealth. This is something we really need to move forward and do. So there's going to be a little bit of extra cost here associated with that. We need some webcams and we need some headsets in order to maintain HIPAA compliancy and bill for ongoing in-time video therapy. The interface from CPSI is going to be $14,000. The interface from their office, $6,000. Their office is asking for the first 3 months up front. So that would be $1,755, and then their office annual $1,000. So that subtotal is $22,824.79. And then if we're looking at a monthly subtotal, which will be ongoing, their office monthly for the clinicians that we currently have at the hours that they're currently working is $585. The reminder call monthly projected is going to be about $90. That's going to fluctuate depending on how many calls we have, how busy we are. But the top, I'm estimating it, the top dollar we would spend on that is $90. And then their office annual, like broken that into 12 months just for budgeting reasons, is $83.33. So that's our monthly subtotal and our purchasing subtotal.
So up above, Grace, are the one-time costs?
So this
Well,
first
some of them
subtotal
are.
here is a, I'm sorry?
The 14,000 obviously is a one-time cost. The interface for their office, the 6,000 is a one-time cost.
These are all one-time costs.
The cameras and headsets are one-time costs. So the ongoing costs beyond the initial purchase then is the $758.33 a month, correct?
Correct.
Okay.
Are the visits that are done by telemedicine, telehealth, are they billed at the same rate?
I had our billing department already look through this. They've already gone through some of our top insurance providers to make sure that First Telehealth will be paid, and it is paid. I'm gonna guess that it's not at the same rate as in person. I don't have the actual figures on that.
Interesting.
Those aren't openly provided to me.
I know there's a push to go that way with this pandemic, but yeah.
Yeah, invariably, like the clinic visits and stuff is actually paid more than less. So I'm interested by that.
Chet, do you have any input on that about how it would be paid? Chet,
Yes.
do you have any input on how that would be paid? Medicare.
Let me first say that I have one comment to start with, and that is that thank you, Grace. That's an excellent presentation.
Oh,
I haven't
good.
had one like this in a long time.
Okay, good.
Really appreciate it.
Great.
Secondly, I do have a couple of questions.
Uh-huh.
First question is, do you believe that the new system will increase your volume? And if so, by approximately what amount as a percentage?
So my first intention there is to retain our current volume. We lose a lot of business. So, you know, there's this like marketing, you have to get someone first warm. So that's when their physician sends us an order and it's a warm client. They haven't first established. We establish an evaluation, we get them in. But if we're not able to retain them for the 12 visits that their physician wants, we're losing a lot of money. It costs more to get someone first in the door than it does to just sustain their care. And right now, as we're operating, we're not sustaining care very well. So honestly, my first goal is to just carry out these plans of care more efficiently. And then I see us growing from there. But right now, I'm operating in a pandemic. So how much it's going to be gaining us right now, I'm trying to get a little bit more steady and a little more even. And then I think I can use all of these programs to break down errors within the system. And ultimately, this is the tool I need to grow the department.
Do you believe that the majority of your increase is going to be from the no-shows, a change in that?
For right now, to start, yes. I have experience with marketing. So I know that once I have us all rolling in our telehealth, I have us all trained in the software, then I will begin my marketing, and I think I can increase our volume that way by establishing more physician relationships.
That makes good sense. I'm sorry. One more question before I quit.
Go ahead.
The percentage that you believe are going to be online, meaning that you actually don't go to see, that don't put hands on the patient?
Mhm. What do I think the percentage is? Well,
Yes.
I would guess about 20% to start.
Okay. Okay.
I already have patients who are interested in this, and I've already had to let go of some patients because we haven't yet integrated this. So we have had a lot of people canceling and no-showing because someone in their house is sick with COVID, and they have to quarantine for at least 2 weeks. So if they've missed the last 2 appointments, now 2 weeks of no-showing, I have to discharge them. And then I can't see them again until they go back to their physician. So some people are like, screw it, I'm not coming back. So
Yeah.
That was by policy because we were having so many no-shows, but the situation basically is that's, that part's good if you can reduce those no-shows. That's great. One more question of those. Do you believe that the way you'll do it, or the 20% that you just talked about being online, will that basically change after the pandemic, or will you keep that in place?
this should be kept in place. You can reach so many more people with telehealth. If you have someone up in, what's the place that's far away?
Lone Pine.
Lone Pine. You have someone in Lone Pine. They don't want to drive an hour,
2 hours.
2 hours to come here, but I'm an amazing physical therapist. Hate to brag, love to brag. I'm really good. So I can totally see how someone would want to see me through their screen versus not seeing me at all.
Self-marketing here.
Thank you, Grace. Great job.
Yeah. So there'll be another section for questions at the end of this, just to reassure anyone who's fighting at the bit there.
Yeah. The comments that we're going to make were the same, as you talked about the growth issues, obviously
Yeah.
the fact that there are people out there that want to have this done but are afraid to come in,
Uh-huh.
that's business we're getting today. So clearly the ability to do this via telemedicine will certainly help us improve volumes from that perspective. So
Yeah, if you're just looking, like the VA has already had telehealth going since July. So it is working for the population. I kind of equate the VA to a similar population that we see. It's working. It's going well for people. I have a bunch of friends who are using telehealth, and I personally already have experience in telehealth. So
Jean, I can answer the question for you. The one-time costs up there could be presented to the pink ladies to cover. Obviously.
I was like,
Yeah,
Good.
the good
idea.
thing about her presentation, she's looking at increasing revenue and doing a good job for our patients. And so I can't see how we could say no to what she's trying to do.
Yeah.
thank you.
And the
She's
Great
only
presentation.
halfway through.
I'm
the
not
pink
even.
ladies would be good.
Yeah, we got
That's
to
fine.
finish it up. We got to let them see the whole thing here.
Okay.
Carrie, I have a question for you, and that is that the interface that is done by CPSI, will there be any ongoing cost increase in our monthly payment to CPSI?
Yeah, there will be. Let me look. Typically, it's about $50 a month. Trying to find that quote.
$6?
50.
50.
50, okay.
The logistics, I'm not understanding telehealth.
I'm sorry.
Therapy.
It's going to be $158 a month for the interface.
I did not add that in.
Ongoing.
Anything.
Do they use their iPhone?
That's from CPSI. So
That's from CPSI.
Mhm. Yeah. Okay. Well, I need to add that into my chart then.
Yeah, they can use their computers, Gene. They can use, basically like a Zoom session almost, is how it would work in many respects.
So
what about equipment?
it can be web-based. So patients will have a portal. So you would use your phone or tablet or computer, and you would sign in. You'd have to have internet access. And then it'd be like FaceTiming if you've done that. So
Internet or telephone?
Yeah. So I'd be on the screen on the other side. I would say, hi, Mr. Joe, how are you feeling today? So I would go through my typical appointment, and then I may step away from the camera and show them how to do a shoulder stretch. Follow me. Let's do some shoulder stretching together. Let's do some deep breathing
So
together.
no equipment then?
No, I just need
Would there be a need for leasing equipment and that could be paid for by the insurance? Bicycle or whatever?
No.
No? Okay.
Yeah, I wouldn't need them to use equipment, like maybe if we wanted to at some point, like if I needed someone to have elastic bands, I might say, a lot of times with my patients, I'll say, order this on Amazon, because we don't sell any products here in our department currently. So we do provide elastic bands, but that's the only thing we provide for free. So like, let's say, you know, I need you to be wearing some heel inserts. I might say, here's the link on Amazon. Why don't you purchase those for yourself? Most of my patients here are able to do that. Some of my patients who don't have the gas money to come to physical therapy, telehealth would be a great option. And I don't need them to do anything. I'm like, as a physical therapist, we're able to do a lot with little equipment. But what we do need is the headsets for privacy and the webcams.
Grace, one of the things, that, you know, again, I envision that the telehealth may help us with is, again, it gives you an opportunity to kind of see what their home situation is. And so trying to understand the care that they need or the kinds of things that they need to do. Because I know in other places I've been, you know, we used to have a program where the physical therapist would go out and do a home visit, primarily more an occupational side than anything else, you know, to kind of assess their specific needs so they knew how to tailor their treatment programs and so forth. Well, obviously doing that while they're in the home via telehealth could assist you in that process.
Absolutely. Yeah. I learned quickly from working here that when I first started, I would give exercises where people were laying down. But I didn't know to say, do these in your bed or on your couch. So I would have some of my patients coming that I got on my floor, but I couldn't get back up. I'm sorry, I didn't think about that. So yeah, it's really good to excellent point, Tim.
Yeah.
Do we need any more discussion? I mean, we should hire her sister too.
That's fine. I have a question. I know in our area, not everybody has internet. Not everybody there's a lot of pay to go phones, you know, so.
We would be missing out on some people.
But hopefully they can come in.
Yeah, I mean, even to speak to that again, I have had patients who come in for an evaluation, but they say, I don't have gas money to come.
Right, and that's
tell
really
me
hard.
Everything you can on this one session. Yeah. And we have some people with those needs and we try to accommodate as
because sometimes if they don't have gas money, they don't have internet access either.
We've had a patient wait at a gas station to get a call from us because they don't have a phone.
Right.
So there are some people.
I've had some go to Burger King or Taco Bell and wait for a phone call because they don't have internet access.
Yeah.
So we need that.
This gets back to one of the things we talked about during strategic planning, the fact that, you know, there really is a need for a certain transportation service here, you know, for that very reason, because of our remoteness that some of our people can't get here. And that, you know, providing a van, like I said, I've been in communications with Current Health Systems. They were willing to consider purchasing us some vans. They did it for Ridgecrest to where we could actually go out and bring patients to us, bring them home, things like that. So, I mean, those are some things we probably.
Is there something we could look at if, so they could have MiFi or something for a certain amount of time so they would have that internet access?
Well, telephones, you can have access, so we could deliver the telephone and have it.
Well, yeah, if it's an iPhone or a phone that has all the internet, but I'm thinking sometimes with maybe if they had a MiFi where they could hook up into it for, you know, whether they lease it or we loan it or whatever to help prevent.
Some of it may do more with signal availability and stuff like that, which probably wouldn't help even if they had the device, you know, so we need to look at those. But yeah, there's lots of options, and obviously the technology has changed so much that there are certainly solutions to some of these things.
But surely offering telehealth is actually us working towards accessibility.
Right.
So for people who are unable to leave their homes, now we can still accommodate their needs. So not everyone, because it's just hard. It's hard. It's an ongoing project. Yeah. So you guys want me to wrap this up?
Yeah.
Yeah, you got more to go?
I have a few more slides. This is basically kind of just going back to, you know, this is Chet's chocolate right here, huh? But this is just going to say how the effects on documentation, the effect on billing, and the effect on business overall is going to drive our profitability. And that if we're looking at the cost of this investment, I tried to work some of the numbers based off the vague amounts of information that I get. And it would cost less than 1% of our revenue to make this purchase. So like, for example, since billing is, I do the charting, I put the billing in and it's automatically gone to CPSI. There's no errors there. And if it takes 6 seconds for me to do that chart, that meant that of my 60-minute appointment with someone, I can bill the entire 60 minutes. So that's just more of my time is billable versus me doing unbillable exercises and activities. And then again, just those. So if you're asking me more pointed questions in the next 6 months, like, hey, Grace, how much profit has this brought you? I'll say, let me pull up this, like, let me just run this report. And then I can give you actual numbers of how things are affecting us. So there's really good promise here, even though I can't draw on specific numbers. So future offerings, like I said, I want to get this patient portal running. I want to be able to email the intake forms to cut down on time they're here. I want to be able to provide appointment reminders. We need this for our community. And then this is home exercise program. So I would like to have their home exercise program also electronic. And then we need to move towards setting up a telehealth program here. So next step, we need to first acquire the software, get the headsets, get the webcams, begin the interfacing work. I will take on training the rehab staff in both the software and how to do telehealth. Like I said, I have now a year of experience in telehealth myself. And clinical use, I'll start getting those reports going. I'll start trying to pinpoint areas that we need improvement. And then, I didn't remember what this last one is. Marketing. Yeah, so that's my next step is then I'll go to more of our physicians in Bakersfield and I'll say, look at how amazing we are. Don't you want to send your people here? And they're going to be like, yeah, we really do.
And that's going to help with when you're cancellation or people not making, you're going to have better customer service saying,
yes,
we have met, all of the sessions, and that's going to be huge in itself. So
that's really important. Yeah,
Good
physicians
point.
are,
Good point.
especially with what's been happening in the last 6 months, like physicians are super annoyed when we don't finish the plan of care. Of course, it's the patient's fault too, because they're not showing up, but there's more that we can be doing to help them along. That's my point. So thank you. That's me and that's Bailey. She's a rehab care coordinator. We make sure we have lots of fun over in our department if you ever need a laugh. And here's our point for questions.
Bailey's the one who's actually doing the appointment scheduling for the COVID vaccines, is she not?
She's been quite exhausted, yes.
Oh,
Yeah.
She's working hard.
Exactly.
Yeah, she's working hard.
Grace, one quick question. Assume we get the go ahead on this. Roughly how long would it take us to get this installed and up and running?
I
Any idea?
get a rough estimate on that. I mean, even if we were to sign everything today, CPSI quotes us out at least 3 months to get the interface built.
Wow.
So we're talking, I would say 5 months or so, 4 to 5 months to be up and running with this, optimistically.
Are there pieces?
Excited by then.
Actually,
Yeah.
that's not bad. That kind of coincides with the end of our fiscal year. So
Yeah.
that's not a bad thing. More importantly, to get it right than to speed it up.
Right. I agree. Okay.
I got a question for Carrie more. How does that, don't we have a program that would work for the clinic that could be modified to work for her? I
No.
mean, why?
Well, I mean, it's just based upon vendor deciding where they're going to invest their time and money to build a product, where right now we don't have that. We have, with several different EHRs, none of them are designed for PT.
Do the other hospitals in our area, do we have an agreement? Do we share anything or do anything together?
We do not, in terms of sharing EHRs, no.
Okay, if we don't, and if there's no more discussion, we should send it to the consent agenda.
Okay.
And you're doing great.
Thank you.
Great
Yeah.
presentation.
Great
Grace.
job.
Thank you. Thank you so much for your
Fantastic,
time.
Grace.
Thank you.
Thanks for the time you put on.
Okay. Okay.
I just needed the dollars on that. Because that's the one I'm gonna talk about.
Okay.
Did you guys want me to email you this deck or? No.
You can go ahead and send it to me, Grace.
Okay. It's nice. I didn't get your name. I'm
Oh,
sorry.
my name's Catherine.
Catherine.
Barbara.
Barbara.
Jean.
Nice to
Jean
see
Parks.
you.
Thank you.
Nice to see you. Thank you for your time.
Thank you.
Okay, Carrie.
Thanks.
I'll say a later. Bye, Heidi.
Yeah. Well, I have horrible news, everybody. I do not have as fancy a presentation. I wish I would have been first now at this point.
That was your wish there.
Yeah, she's a tough act to follow. there.
Goodness. Can I just quit now? All right. Well, let me stop sharing the screen so you can forget how nice it looked. All right. Okay, so what I want to talk about is, I'm stealing Jean's packet so I don't mess up any numbers. I'm proposing we purchase a hospital portal intranet site. What this will do is solve three needs that our hospital currently has. Number one is policy and procedure management. Right now, we have a repository where our policies sit. I can't talk with this on, I'm so sorry. Where our policies sit and they're accessible. However, there's no accountability, there's no auditing, there's no means for sending any employee notifications when a policy is updated or changed or anything like that. Where this is a policy and procedure management software. So notifications would go out when policies are changed. There's change history. It's designed to work for hospitals, specifically for their policies. Secondly is a fillable forms. All of our forms are paper right now. There's a running around that happens once you get whatever form you need filled out, signed. You got to go to the right department head, get that person to sign it, and you're tracking it all over the place. This would allow for all of our forms to become digital, meaning you would sit at your desk, you would click what form you need to fill out for whatever, you would get that form, fill it out, and then it would send to the correct department head so that that person could do what they need to do. And if there's multiple signatures needed, that can happen too. So that will be a huge thing in terms of reducing paper waste and time saving as well. I mean, I can't tell you how long it takes sometimes to just like run something up, repeatedly through the day to get something purchased or whatever else may need to happen.
I have a question.
Yeah.
Right now, we're doing something like that with our charge.
Yeah, there's a couple, I shouldn't say all of our forms. I've made maybe 5 forms out of the 700 probably we have that are fillable, but there's no tracking that. There's no, okay, this needs to go to Chet for signature automatically. It's still a weird process that doesn't really work very well. This would be a vast improvement on even that. Thirdly, communication. This would improve communication in the hospital because it would be a single stop shop for announcements, and you can do different announcements for departments. If Grace's department were to log on to this thing, they could have their own area where department announcements could be made, as well as, different HR things. When it's time for open enrollment, it's an easy way to communicate that. And I mean, communication here, it has been identified as something that is lacking. And so this would give us an area outside of even email that would be up front and center for every employee to see whenever they logged onto their computer. As soon as they open any web browser, this would pop up. So this is replacing what our links page is currently. For those who are familiar with it, our links page is basically just a site. I could pull it up, but it's just a shortcut of web addresses that makes it easy for people to go to browser shortcuts. And so
resources.
that, but this would be a vast improvement on that as well. We would obviously still be able to have those shortcuts for everybody, but you would be able to kind of bring it down to what's important for this department, so you're not looking at everything at all times.
Carrie?
Yeah.
Couple questions. First, would just employees that you allow to get into the portal be able to get to it? Or would anybody be able to get to it?
This would be restricted to the hospital only, so you'd have to work here to be able to get to it. It's not going to be open to the public.
Okay. Secondly, how about changes? Would anybody getting to it be able to make changes?
No, changes would come from either the department manager, because training is included in this cost, where somebody would, well, it wouldn't be on site now, but there would be these web trainings that we would take place with an actual instructor, where all managers would have to be on board with this. They would have to, if a manager has a form they need to make digital, which is, we would want to require that for all managers, they would need to attend that training so that they understand how to do that, because otherwise it's a waste. We need to be committed to saying, okay, all departments need to have their forms digitized by a certain date. And then any content that you would want updated for your department, that manager would be responsible for as well. Now, even our beloved Mark Gordon here has been able to do some things with this company in terms of our COVID portal. We have a COVID update portal that internally we distribute information for. And so Mark's been able to get in there quite easily and push that information out via this web portal. And if Mark can do it, anybody can.
One more question, Carrie. Is the driver for this all in Word, or can other programs be used?
In terms of what, forms?
Yeah, in other words, what's driving it? Could I take another program and use it on this portal?
No, you'd need to recreate, in terms of forms, you would need to sit down and recreate your form in this portal. And there's tutorials that would walk you through it. And again, like I said, there's training that would walk people through it. And it's relatively simple, but it would take time to do. You're not just going to be able to grab your Word document and throw it over and it's going to recognize what needs to be filled.
Yeah, that's the question. Is the base Word or Access or something else?
It would be HTML5 is what the coding would be.
Okay.
But you don't need to know that coding to do it. I mean, it's just going to walk you through, whatever fillable field you want. You would just type that in, and then, it's $1. So you would make that field need to be reflective of a dollar amount per se.
So as I look at policies annually, I can go in and make changes to them. I can go in and initial off that I reviewed this policy. Is that something that this?
Correct. Yes. So based upon our HIPAA risk assessment, all policies should be reviewed annually. Yeah. And that's not really being done. I mean, some policies are, I don't even know how old, certainly older than a year since they've been reviewed. And so we could set dates for managers to have to go in and say, yes, this policy is still valid, or no, I need to make these changes. Now, policies, you can upload documents to. So you wouldn't have to rewrite all of those policies. So we have PDF versions of pretty much every policy, minus probably a ton that are still on paper, but so we'd be able to upload those to this portal.
One last thing, Carrie, is this a one-time cost or is it ongoing?
So the one-time cost is what I have quoted here at the top, which is the $13,202.07. And that includes, everything that's going to take place in the first year, including training and such. Now the ongoing costs, let me flip to it real quick. I think it's $8,000 ongoing. $8,200 ongoing.
Annually?
So annually, $8,200 annually.
Those are what, licensing fees and what else?
I wouldn't say it's licensing. I mean, it's just access to the product. They're just going to charge us an ongoing thing.
Web-based?
It is web-based, yeah. So there would be no equipment we would need to buy or anything like that. No equipment we would need to maintain. Doesn't use any of our storage.
Could they
I'm sorry, Gene.
So the annual subscription fee is based upon the number of FTEs that use it?
Yes.
Correct.
And you have to commit for 2 years, and it's $8,204.08 per year.
Correct. So that FTE is actually, since we have part-time employees, we calculated that we have 250 total employees-ish. And so we calculated the full-time actual employees combining the hours of those part-time would be about 170.
It sounds like a good thing. Could they bar us if they don't like what we're saying on there?
Oh, no, you can say whatever you want.
So it's not run by.
Well, this is good for the board because the board, instead of having to come in and look at those manuals, they can do all this stuff online from home or, whatever, they can just dial in. Correct.
Good for
The
Heidi.
other thing too,
I said it's good for Heidi too.
yeah,
You don't
very
have
good
to
for
carry
Heidi.
all those manuals everywhere.
Right.
She's gonna have to find a new way to work out or something. Well, back to what you said, Tim, on the board getting on here. Yes, we could, but we'd also have to set up some sort of VPN access. Since this is gonna be only accessible internally, we would have to do some sort of access control there to allow them to do it,
Yeah.
but possible, yes.
I know we talked about that in the past, obviously, is one of the things that would certainly be a benefit for their reviews and so forth prior to coming to committee and so forth. The other thing too, I wanted to ask, again, this is similar to other systems we've looked at before that will send reminders out to the managers that a policy is due to be reviewed. And does it do those kinds of things?
Yes, absolutely it does.
Good.
So there's setup involved there, and then there's accountability that still needs to be pushed, because if the manager just gets a reminder and they don't have to do anything with that reminder, well, okay, there you go. But it's a useless
We'll give us
reminder.
reports of who's not doing that or whatever.
Yeah. And then exactly what you said, you would get a report that, hey, this guy, Kerry, hasn't done his policies in 3 years. You better go write him up or something. I don't know.
Yeah.
So the efficiency, it sounds like, we will be more efficient and more revenue, everything. It shouldn't.
Well, it's not going to generate any revenue. It would just be.
It will if people are able to do their job better.
It's a tool for people to be able to do their job more efficiently. Yes.
Yeah, so that's more revenue.
It's
Well, and
more
there's the
management tool.
responsibility. There's responsibility we have to obviously to make sure that our employees understand the policies and so forth that they're working on. And as changes are made, sometimes it's very difficult to get those policies out to everybody to make sure that they've read them and follow them. So this is a big step forward from that perspective.
One of the questions that CDPH asks for is when you do a plan of correction, how did you notify your staff of the policy change? And that's a common thing that we have to do. Usually we end up taking the policy, hand carrying it to every employee saying,
Sign it.
Sign it.
something like this, it's just going to make it a lot easier.
Could
Plus,
we
That's a
put-
good point.
They're
could we put-
accountable for it. Once they log into it, they can say, I signed it, I read this. So they're
Correct.
Cool.
Will this do away with all the manual ones we have sitting around?
Again, that's going to fall on the department managers. It should. I mean, my hope with this is that every department manager is going to take it upon themselves or be directed to do so, at least, to take their policies. You need to, if they're on paper, type that policy up so that we can upload it to this. This is our platform for policies. Paper
You still
policies
have to
go
have
away.
paper policies in
You
place.
still do?
You have to have at least one copy, right?
Sure, but
One
That's
last
just to
question,
having-
Gary. This being based upon, the annual fee being based upon number of FTEs, is there a floor on that? Or if something happened and you went down to 150 or you went down to 100? And is there a ceiling on that? Let's say you went up to 250. Is there a ceiling or a floor on the number of employees?
it's a range, if I'm understanding it correctly. I don't know what that range is, if it's between 170 and 190 or
Those
I
tiered,
have to look, but it's roughly what we have here.
You could probably have Grace
Like-
do a PowerPoint.
I should have Grace do a PowerPoint.
Yeah, right.
I just feel ashamed the whole time I'm speaking.
Grace would know.
You just set a new standard here, unfortunately. So-
I do not support this PT thing she did now all of a sudden.
Okay, it sounds like from this program, we could put Heidi on part-time because
Heidi will
it's
have
more
more
efficient.
time and more things will be accomplished because she'll
Wait,
Okay,
just have to push
if
it.
there-
but
if
who's
there's
gonna
no-
be doing the typing? Who's gonna be putting it in?
The managers are going to have to do that. This is too much for one department or one person or
Right.
10 people to do. This needs to be something that is required by managers to do. All of your forms need to be done in here. All of your policies need to be in here.
And when are they gonna find the time or have the time? Because I've just listened to people at meetings going, I don't have time to do that. I'm too busy, I can't do that. So
Well, sometimes you just got to make the time.
I'm just saying,
I get your point, but
but if we do this, are we gonna say, okay, you guys need to have, you have 6 months?
yeah,
all that
that
needs
would
to
be
be
my
put in.
plan to do something like that, to
They
say,
have to have
We
Because
would
it's
have
gonna
to
be
set a
hard.
deadline to say,
For the managers to be doing, it's gonna be hard.
We've offered
No.
typing and entry assistance for any managers who need it, but they need to
Okay.
review the content. It's difficult for us that aren't operating in that
Right.
department to know what they need to do. Be happy to type it up, but I can't guess what you mean. I need to know
Right.
word for word what you want it to say. And we've had a lot that have just not taken that either.
Speaking from my own experience, it did take me several days and several hours to bring all of the nursing manuals up to where they're at today to be put into the system. And I'm more spending time maintaining them. But I had to dedicate 8 hours for a day for about 3 days, I think, just doing that only thing. So yeah, you have to do it. You have to make time for it. They're not
So
going to. That's part
Once
of
you get it, once
Carrie,
you get it done, though, it's
does this
easier.
system remind you of your employees that haven't reviewed a policy or that you haven't updated
Yes.
the policy?
Yeah, if you have employees that need to review a policy and they haven't, you'll get reminders that says, you know, Chet hasn't done this yet.
there's a tickler file.
And then back to your comment, Catherine. I mean, like, yes, will it take time initially? Yes.
Yeah.
Will it take more time than they spend initially? Yep. But
Once it's in
once
there.
it's in there,
Yeah, once it's.
just
in
like
there,
Mark was saying, this is
the
less time
problem.
now. Now we're maintaining something rather than getting 20 years behind on a policy, which there are policies that are very, very behind.
Have no doubt.
1992, baby.
Yeah, which is crazy.
I'll roll some of those.
So, I mean,
Yep.
this is a requirement that is going to take more time, but it's a needed time that we should be doing already. And this is just a tool to help us maintain that. I mean,
So, is there something we can do? And I know this sounds kind of ridiculous, but incentives to get them to do it? Because people aren't going to just get in and do it because they're going to say, I don't have time. And I get that. We have a lot of things we want them to do, and managers usually, if someone doesn't show up or they're helping fill in wherever they need to. So I just want to have a clear picture of that. Yeah,
Let me say that over at Tehachapi, we use a system like this. And what it is we don't give any incentives, and Advance still uses it for their employees as well. But what it does is it reminds you so much, you really can't forget it. Employees, the managers, the reminders are the big key. Boy,
It'll annoy.
but not in the beginning. Not if those there aren't going to be reminders in the beginning as we build this process.
Yeah.
We're
That's a good
willing to help any managers that
Right.
need the help to facilitate it, but they have to be involved in the process. They
Right.
can't just ignore it.
yeah, what should not happen is, oh, I don't understand how to do it and throw my hands up.
Right, or I don't
That's-
have time to type.
that's
I'm not that
ridiculous.
fast of a typist or
So,
whatever.
I mean-
That's my
We will do that
concern at
for
the
you.
beginning.
We are paying for training for the managers to understand how to do this. And so there really shouldn't be that I can't, I won't type
I know, but in
statements.
the beginning, it's going to be,
It's overwhelming.
It will be overwhelming, sure.
Overwhelming, yeah,
For some that have done a good job maintaining their policies, this will not be overwhelming.
right.
And then for the forms, you know,
Start with the most important.
start with the most important ones
That
or,
you use the most often.
yeah, and then roll it out.
And
from
I
there.
think the program will be great. I think anytime, I know there'll probably be a lot of shredding after they're all updated, get rid of the old ones, but no, I think it's a great program and I think it's the way we should be going.
Mhm.
I mean, we should be going that way. We're probably way behind in that type of,
In this area, certainly we are.
yeah, so. Okay, no, I think it's a good idea.
It's pretty user friendly, though. You know, you're
Yes, it's very
talking
user
about
friendly.
having to learn how to do things, but it still sounds user friendly. Okay, any more?
I will also say that you're really in the ballpark from Mike's perspective for this, simply because the program at Tehachapi is 11,000 a year. Just to give you a comparative.
How big is
And
Tehachapi?
the number of employees we're using it is pretty close to the same, around 200 employees.
But our employees are smarter.
Some are,
Right.
some aren't, I'm sure.
Let me ask a question, Carrie. You know, again, because we have so many policies that Heidi has already typed up, they're already in an electronic format.
That's
Those
good.
aren't going to have to be redone. Those can be uploaded, correct?
Yes.
Okay,
ones
so
we're
we're
gonna
not starting.
struggle with are the managers that have ignored them for years. Those are gonna
Right.
be the ones that are gonna be the most time consuming. But for the managers
Right.
who kept up on it, it shouldn't be too bad.
Right, that's a plus. So we're not starting from ground zero.
Correct.
And the incentive would be if they don't do it, maybe it might hurt their job.
Well, this is something I think would go on their,
Evaluation.
Evaluation,
Right.
exactly.
right,
Good
like
point.
definitely on the evaluations, because that would be, you're gonna see that they've done it and that they've kept it up, you know.
So we don't want the board members to be on there, like he was talking about.
I would keep up my share.
Okay.
I'd love to evaluate Gene.
Should we send the consent agenda?
Board P and P will be easier with this policy management
Yep.
tool.
Absolutely, there's no question
true.
about that. Okay, it's gonna go to the consent agenda.
Great.
Right.
Thanks, Gary.
Thank you, guys.
These guys.
Good presentation, Carrie.
I mean, can we rate
Not as
mine with
good.
his graces?
But it was good.
You wouldn't want that.
I don't want that to happen.
And can I stop by to do my email?
Yes. Yes.
Okay.
I sounded questioning, but yes.
And are you gonna go take care of my computer?
Yes, I'm gonna do all these things.
I can help you with your computer because I'm finance.
Gene's gonna come up and help.
Thank you.
Set up a video monitor?
Okay, next is Barbara, I think.
Yes. Okay, so we're reporting on the month of December, and the first page we'll go to is 17, which is the statistics at the bottom of the page.
Catherine, for your benefit, there's two numbers. There's a top page number, and the bottom page number. They're different. And you're going to the bottom page, number 17, right?
Yes.
Right.
Well, I didn't understand till you told me 3 times.
Well, thank you for ensuring I got there.
So about middle of the page, the average daily census in the acute for the month of December was 4.1 with a 0.90 in the swing beds for a total of 5 for the month. Our budget was to be 5.9 total. Year to date, we're at 6.6, and last year we were at 6.5. The SNF had an average daily census of 48.7. The budget was to be 55. Year to date, we're at 49.2. And last year for the same period, we were at 55.5. ER visits remain down. There were only 449 for the month. However, we admitted 7.8% of those visits. Year to date, we're at 3,097. And in the prior year, we were at 3,675. Outpatient visits, because of all the testing, is up 2,646 for the month, which is 15, is almost doubled what we budgeted for. Year to date, we're at 8,364, and last year we were at 6,576. Clinic visits still remain high, 1,431 for primary care visits for the month. Year to date, 9,620, and in the prior year for the same period, 8,446. Now they also have specialty clinics. They had 335 for the month, budgeted 261. Year to date, 1,784. Prior year, same period, 1,767. They did have visits in the mobile van in the month of December because they began doing shots. So they had 80 visits recorded for the mobile van. And the retail pharmacy, they filled 3,520 scripts for the month, which is slightly over what was budgeted. Year to date, they're at 19,874. The prior year for the same period, 21,394. So they're a little behind on the year to date. Does anybody have questions on the statistics or the volumes? You can go back to page 12, see the revenues and expenses for the month. Our revenues were 9,492,000 for the month. The same month prior year was 9,375,000. It's still 858,000 below our budget because of the outpatient, which is primarily the ER, the lack of revenue there. The long-term care is down. Inpatient revenue was slightly up during the month. After our deductions from revenue, we had an operating revenue of 2,131,000. The prior year, we had 2,300,000.
Barbara,
Yes.
can I make a recommendation to you?
Mhm.
Between the deductions of revenue and the net patient revenue, can you insert a line in there that actually is the percentage of gross revenue that the deductions are? It's very helpful.
Okay.
Yeah, I noticed that. I was looking at that last night, Chet, because if you take a look at the discounts and allowances as a percentage of gross revenue, if the prior year was 73.25%, I think it's up now 75%. So I mean, we certainly saw a decrease in the amount of money that actually flowed to the bottom line, assuming that we had the same book of business. So, and I don't know if that's the impact of some of the outpatient stuff that we've done because of the shots and the reduced revenue per occasion of service or not, but yeah, clearly not as much of that fell to the bottom line as we would normally see. That was about $200,000. That was almost $200,000 worth.
Yeah, the payments in advance, Chet, how is that figured in here? Like we got that 1 million payment in advance from.
Well, if it's something we know, if it's something, and this is the income statement, okay? So if it's something that we know we're not going to have to pay back possibly, or then we actually, by statute, by the accounting regulations from the state of California from MOSHPD, we have to put into these numbers. But that doesn't have to happen until the end of the year before you do an OSHPD report. So it's a situation where even then, even at the end of the year, and I just discussed that with our bond people, you take a conservative approach. You put it on the balance sheet. For example, the PPP is on the balance sheet.
Mm-hmm.
Once it's forgiven, then it moves over to the income statement.
Right.
You take a conservative approach. And what I do is discuss with the auditors at the end of the year what they believe is they can allow to go in there for that and what has to stay on the balance sheet. It's not something that's a board decision. It's something that's an auditor decision and how you have to do it, how the state tells you have to account for it.
Okay.
It's certainly not something that we can do. For example, if I wanted to put the PPP on here, I couldn't because my reporting would be incorrect.
Right. Okay. I understand. Thank you.
Yeah.
Sorry.
That's okay. So our operating expenses for the month were 2,674,000. The prior year, they were 2,352,000. And with our non-op.
I was gonna say, Barbara, can you focus a little bit as to why that went up and the significance? Again, for example, please notice purchase services were up by over $200,000 over budget and so forth, and substantially up from prior year, 178,000 over prior year.
Right. And we have a lot of extra expenses due to the COVID for the PPP or PPE and other things that Christine is having to order.
Look at the big one, Barbara.
I know.
Big one is purchase services, and that's Quest, and that's almost totally related to
COVID.
COVID.
Precisely.
It is Quest, the charge of sending out all those COVID tests that we did in the month of December. We did a huge
$100 a test, right?
But the county's giving us the money back, right?
Well, the county is giving us some of that back.
Okay.
Yeah.
And the bill
part
for
that they're not
Quest was $200,000 in the month of December.
just for the community testing. We still have testing that we are required to do on our employees. Every week, our employees are getting tested in the SNF. There's 80 to 90 employees every week that are getting tested over there. That doesn't come from the county. That's coming right from us. So that's a big part of this here too.
Right.
We tried to make it come from the county separately, but it didn't work.
Yeah. Yeah. They didn't buy into that, so.
So after our non-operating revenues, we ended up with a loss for the month of $498,000. Last year for the same month, we were at a loss of $55,047. Does anybody have any other questions on the months to date? We did, if you note at the bottom, you asked for the IGT payments and receipts to be recorded. The very bottom of the page, in the month of December, we paid out in an IGT $1,398,000. It'll show up in the cash when we get there too. The following page is the year to date.
Do you understand the IGT? Do you understand the IGT?
Well,
It's confusing and I'm not, I want you to understand because you should.
Those are governmental transfers. It's additional supplemental income that.
Jed, could you explain?
that we get.
Yeah, Jed, could you
Yeah,
tell
some
her?
of them you have to front. You have to pay the $1.3 million to get back $1.3 million or less. depending
What
on-
actually happens, the majority of this is Medi-Cal that it comes from, okay? And where they find, there's two parts, where they find that your Medi-Cal reimbursement during the year for what they've, by fee schedule or whatever, is less than your cost. They have to reimburse the cost because the federal regs say that they have to pay at least allowable cost. So what happens is the state says to us, we'll go get the federal portion that it's not coming through there because 50% of all Medi-Cal money is from the feds and 50% is from the state. But they say you have to give us the state portion because we're not going to match that. The state is not going to do it. So basically, but we give them the state portion, then they go and get the federal portion, and they give us back both of it. So example, let's say there's $1 million that we were looking for, okay, that we haven't been paid cost. We got to pay them their portion of it, which is $500,000. Then they're going to go get $500,000 from the feds, and then they're going to give us back the $1 million, less a fee of 30% for collection.
Yeah.
Because they collect it.
Thanks, Jed.
Thank you, Jean.
It'll sink in. It'll take a little time, or at least it did for me. Thank you.
Okay, so page 13 is your year-to-date numbers. Year-to-date, that leaves us with a loss of $777,000. And in the prior year for the same period, we had a profit of $61,000. Now you can see the IGTs on the bottom. So far, the ones year-to-date, we've received on one $810,000. And now our total payments have been $1,803,000 because the 1.3 is added to that.
Okay.
So we still have more coming in, obviously, because of the payments out. We just haven't received them
Right.
back, correct?
We just haven't, it takes
Months.
They pay.
Yeah.
Barbara, at what point in time do we book the audit adjustments from last year? I know we've had the audit and so forth. Have we got those entries there?
I have it set up. They're not entered yet. Ideally, I would do it for the month of December. I'm trying to get them in the month of December.
We've had Barbara really working on trying to justify keeping the HHS money and the PPP money. And there we're talking about almost $7 million. So it's
important. It's important.
hard on that.
Keep at it. Keep at it.
Time
Just
involved.
Mhm.
And it's
You
time
betcha.
for W-2s and 1099s.
And you're gonna have to
Yeah.
do your policies. I'll do yours. I will do all of yours.
Mine are not bad.
No, yours are not bad.
So we were on page 13. Page
Sorry.
24 is the next page that we usually review. If you have any questions on any pages, Catherine, then you can ask.
I will. Thank you, Barbara.
This is the page that we calculate our days in the accounts receivable. At the end of December, they were 81. And our days in our accounts payable were at 40.8. Just for information. Page 26 is the next page that we go to, which is a debt service ratio. This has to do with the current bonds, the way the bonds want us to report our debt ratio. The current debt service ratio was a -10 in the month. We're required to be at 1.25, and the total current ratio is 0.5, required to be at 1.4.
I do want to make a point here. All these ratios that Barbara's talking about for the revenue bonds are from our non-audited financial statements at this point. One's for the audited financial statements where they have the auditor's adjustments in them. I have to send a certification to the trustee of those bonds, which I will for any of the new bonds if they're approved as well. And I was just explaining actually, I think yesterday to Gary Hicks, our financial advisor, we have one bank that's interested, for example, that wants to know why in 2017 we had one of our met our ratios out of compliance. We have actually been in compliance after the audit for almost the last 5 years. So I just wanted I want to put that in perspective.
Yeah.
Thank you. Okay, the following page is a bond requirement page also. We're required to fund a certain amount of capital for the year. The current year, the target number was $534,000. We're currently at $469,160 towards capital. And in the middle of the page, it shows you what the payment schedule is. February 1st, the interest payment of $38,588 was due. The bottom section shows you what was on deposit to make that payment. So the payment was made. The next payment on these bonds will be August the 1st, and our amount will be $773,000, which will start funding into the bond accounts to make that payment when it comes due.
On the other hand, it should be gone by then because we should be converting over to our new bonds.
Correct. Yeah. Good point.
And so that's all the first part. This is now Chet will start addressing some of his.
Do we have to listen to Chet?
Yes.
Unless you wave him, Gene. It's fine.
Oh, you guys heard that.
We can hit that microphone is real sensitive.
Okay, product line analysis. This is on page 28 of the packet. And I'll talk about these again, if anybody needs to go into them more in depth. You can see that the first one is medical surgical. That includes ICU, acute, and swing. It also includes any ancillaries that are related to the inpatient services, basically like respiratory therapy or observation. All that gets rolled into a product line. So the product lines basically have inpatient and ancillary services, or just ancillary services, or a combination of both. And I'll note that when I go through. So one of the things that happened in the month of December is that our inpatient acute was actually not too bad. It was pretty good, even though we lost $500,000. You're actually above budget, or it'll slight in dollars in there. So you can see that although we were scheduled to make $106,000 in profit for that product line, we lost 47. And the main reason that we lost 47 was a decline in the swing bed patients. We haven't been putting as many patients in swing beds as we were in the past, not for therapeutic, nor waiting for COVID, as those are now basically, if we don't know they're COVID, they're going to separately, basically the color-coded units in the SNF. And so the situation is that it's a reduction for the most part in our, it's a reduction in our swing volume, plus you look at down there under labor and fees, 224 versus 24,000 versus 200,000 approximately. A little bit of that is the cost of staffing flexibility in our nursing staff. Okay, but the majority of it is the physician's fees guarantee. We guarantee our physicians a minimum, no matter how many patients we have in the unit, in the med-surg unit. So that doesn't change. When it doesn't change, then obviously you're going to have that fixed cost in there. Any questions on that? Let's go to the SNF. The SNF, you can see, is substantially down, as it has been, from the budget as far as dollars in revenue and number of resident patient days. You can also see that if you go down to the next section, the expense side in this is pretty well managed. You can see how they've come down in dollars in labor and fees. We don't have much in physician fees in the SNF, only the medical director fee. And they actually are pretty good about ratcheting down. They don't always do it, but they're pretty good about ratcheting down to the minimum staffing that's required for their labor. So you can see that although our budget was to lose 127,000 because of the lower volume that's been out there, even in the budget, we only lost 92. And the reason for that, again, is their flexibility with their labor and physician fee costs, mostly their labor costs. The ED, again, remember, has all these things in it, like the outpatient CT for ED patients, the laboratory for ED patients, the EKGs for ED patients, all those kinds of things are in here. And I would say, example, probably 85 to 90% of all our CTs are ED CTs. Very little stays in imaging for referred patients. So they pick up quite a bit of revenue. The same thing from the lab. Most of our lab comes from the ED or the inpatient side, not from the referred outpatient side. So they pick up, you can see that the revenue actually, even though it wasn't quite as high and the volume was down fairly substantially, the revenue per unit isn't down as substantially because it depends on the intensity of those ancillary services. So we have 3.8 million. We actually were at 3.5, but our volume actually is a little lower than that as a percentage. The other thing is they actually, although they have a certain amount of fixed staffing, their fixed staffing is not quite as high as our budgeted fixed staffing, if you will. We actually budget, relatively speaking, for visits, but they do a little better job of that. So the situation comes down there to, and the major thing is the difference in the revenue generation from the drop in volume. So they actually had a profit of $305,000 for the month of December, even though their volume was way down, versus the budget of 334. Again, the volume can be down in the ED, but it depends upon the intensity of service regarding the ancillaries. That will drive a lot of things in the ED. The Rural Health Clinic, they're just booming for their volume, and we hope it gets even better. That's our hope. You can see what it does to revenue from 570,000 to 815. And then you can see what they also do is they adjust their staffing. Now, some of that has to do with changing over from a physician's fees that's in the budget to a mid-level salaries. And that's going to be some of your difference in salaries is the type of patient provider service that we have. So when we end up, even though they are high in volume, some of it has to do with some of the fixed overhead, except look at the overhead, for example, there. And then but still we ended up making 173,000 versus 180 budgeted. Our surgical services, those poor guys,
Hey,
you
Chet,
know, look at their volume. Their volumes. I'm sorry. Go ahead.
I had a question about the ED. And I'm just wondering, the patients in December that went back to the ED as ICU patients, were they ever counted in that ED number, or is that?
If they're re-registered, they would be. If they're
Okay.
not re-registers, they would not be.
I'm
But the
not sure how
revenue-
we manage that.
All I'm saying is because it's whatever, it's wherever they're registered. That's
Gotcha.
where that's gonna
Okay.
go.
Thank you.
Okay, surgical services. I really feel for these guys because you can see they're right on budget with their volume. And this both includes both surgeries and endoscopies. They're down a little bit because it depends on the mix of surgeries versus endoscopies, what they have right there, and the amount of, because the things that are in here are things like anesthesia, blood, not just the surgery suite, okay, not just the nursing, but it takes in, again, the ancillary services that are associated with that. How, also in here is the PACU, so the recovery room, how long they were there. So that'll fluctuate a little bit. But you can see that they're basically, their expenses are even a little below what the budget was, and they're down to about as low as they can get. And still, we lost 80,000 versus 33,000 loss in the budget. And it's simply a fact overall. If you look at the overhead costs, although they're down a little bit this year from the last cost report, they shifted a little bit to the SNF. You can see that the overhead costs, fixed costs from just the unit and the building, the bills, things associated with the building, is 113,000 versus a budget of 108.
I'm trying to push some more outpatient procedures that Dr. Gross has been doing, like paracentesis. I'm trying to make sure that those are being done in the PACU instead of in some room on acute care or over in the ER.
That's a great thing. But we
How
just
do we
need to
make sure that gets applied to that department?
What your nursing anywhere doesn't get their time split. Like when they're working on those, if you want to have those go into referred outpatient, you got to register them as an outpatient.
They are.
Okay.
Yeah.
And secondly, you got to have those go into outpatient if you don't want them in the surgery. If you just want the surgery to pick up the revenue, you can leave them in the surgery revenue, but make sure that they get charged, not what they would be on an outpatient basis, but what they would be by using the surgical suite on pre-op.
Okay.
Does that make sense?
Yeah, I'm going to have to see that.
You can't adjust the rate down and expect it to work. You got to charge the rates for those units because that's how it's if you're going to leave them in surgery.
Okay.
Yeah.
We're going to have another separate meeting so I understand it better, so I can tell them where to apply those charges. But
yeah,
I think that's going to happen more often.
Okay.
Yeah.
Referred outpatients. The majority of the referred outpatients, because and these are patients that are referred by either our clinic or outside doctors into the service and registered as outpatients. You can see the high number of actual number of registered outpatients there. That's because of COVID testing. I mean, those patients are registered. They actually are registered as outpatients because that's what they are. So that flows from that. Okay. But the majority of the revenue is generated from imaging. We still get a fair amount of diagnostic radiology and ultrasound that's not in the department like an ER or in acute. So that drives the majority of this. Very nicely enough, we've also been, and I can't tell you why, other than the COVID, we pick up a certain amount of lab work. Even though we have outside reference labs, we still pick up a fair amount of lab work. But anyway, you can see that they're running a little bit higher, not nearly as high as the volume, but again, the COVID patients testing certainly doesn't bring in much revenue. I mean, it's a low revenue item and a big cost item. That's why you've got the difference. Okay, so you come down there to where you actually at the bottom see that they still were able to make $68,000 rather than the $98,000 that they were budgeted. In rehab, we just heard from Grace. Okay, so that's great. You can see how far down the volume is. And that's one of the reasons I ask about the building up of more treatments, if you will, modalities. And so I really hope that that this unit, this service, basically this software that she gets, will have her either through telemedicine or otherwise build that.
Hey, Chet, real quick, I want to go back to refer to outpatient. I had a conversation with Clinica the other day. They want to come back and reestablish relationships with us. Apparently, there was some corporate directive about interacting with us. Don't want to go into a lot of detail on it right here, but apparently a lot of that is cleared, and so they want to sit down and explore opportunities that they may have for their patients to begin using us more. And so get started on that right away.
That would be very helpful. You know, for example, if they want a digital x-ray for their patients, for crying out loud, don't send them all the way down the hill.
Oh yeah, no, they've been sending those to us. Yeah.
The one thing they do send us, Tim, which sometimes, I will say, which sometimes is even better than some of our other payers or plans. They send us, Dr. Abramson sends Dr. Buxton the surgeries.
Yeah.
She does get those. If you look, for example, the two he's got scheduled right now, one of those comes from Abramson.
Yeah.
And she has for a long time. So we are getting their gastroenterology endoscopies, and we are getting their surgeries, which is very
they're interested in seeing what more we can do for them. So I think that's a great opportunity.
That would be great. But basically on the rehab services, it's a volume issue overall. And it's a situation where I hope their telemedicine coupled with their time reductions, because you can see that also, look at the labor there. You can see it went from 67,000 budgeted to 49. So it's not that their expenses are dramatically out of line. It's that their volume is down so far.
Correct.
So we hope that works. That's really the reason. That's the major justification for that service, not to reduce hours, but to beef the volume.
Build volume. Excellent. Absolutely.
Okay. So that's the product lines. The next thing is on the next page, which is page 29. It's the 13-year listing of the liabilities. There's nothing really remarkable in the liabilities except, see that $11 million down there? That's really current. That's where you asked me, where does it show up as far as the IGT? Well, until there's an audit on 2021, that's what you're going to see. You're going to see that, or that, I'm sorry, that $16 million down there. You're going to see that $16 million. And if you look back at other years, we don't adjust this after the audit. So that carries forward during the year. And that's where that IGT money sets until after we do the audit. It sets on in there as a current liability, due back possibly in 1 year. And it's bigger now than it has been, simply because we have $4 million in HHS money that we're trying to justify that they want back. And we have 2.4 million in PP money that they want back. Okay, so we have to actually persuade them that they don't get to have that back. For example, the 300,000 that we talked about that the county wouldn't cover for the quest, that now rolls over into justification to keep the HHS money because it's something that nobody else is reimbursing. Okay, and we didn't get it reimbursed. So we got to play those kind of games, and that's what's hard on Barbara too, because she has to realize what somebody else has actually paid or is responsible for, and move it to someplace else. So we're still working on that, right, Barbara?
Yes.
Okay,
Real quick,
Chet?
Chet, on the, I was gonna say under notes payable, obviously between fiscal year ending 6/30/2019 and 2020, we saw a huge uptick in the notes payable. What was all of that attributable to?
the major portion of that is the Cal mortgage giving us the money for the year end.
But that's been going on for some time. So, I mean, I'm just looking, I'm looking at the trend here, obviously 3.2 million, 3.9 million, 3.8 million, then it dropped to 2.8 million, and then it's up to 6.7 million. So I was just trying to understand what new was in there, because obviously that's been coming through routinely for several years now. For the notes.
Yeah, the majority of that is the Cal mortgage if you carry it back. And then you also got things that we know have to be paid back currently. I believe, correct me if I'm wrong, Barbara, but is the PPP in that one?
Yes, it is.
I think the
Okay.
PPP
That
is in
explains
that
it.
one too.
That explains it. Okay, thanks.
Uh-huh. The next one down is actually to give you a 12-month rolling average of where we are with our cash. You can see that the cash receipts through December, if you go down to the bottom line, for the 12 months ended in December, we actually have collected $9.8 million more than we had budgeted. Again, a lot of it, most of this is supplemental money. You can see where it comes in near the end of these last months, March, April, May, June. That's when the COVID was there. That's when we start getting the advance from Medicare, the PPP money, the early money from Prime, all those kinds of things. So you can see that's where it falls into place. And that's why you see it on the balance sheet, waiting for, are we going to get to keep this or not? Which is an audit question that will happen during the year sometimes with the audits, because we're now having audits by Medicare, HHS. We now have basically the banks. We also have to do it on the other side for the now that we're doing bonds, and we have to try to maximize it for the bonds and minimize it.
Yeah.
The revenue side for the audits for Medicare, Medi-Cal, PPP, the feds.
I noticed that I checked that we had that letter that came through just yesterday. I think it was on the payback due to the IGT audit or something like that from 2000 or the
2017.
Yeah.
At 17 and 18.
That,
yeah, we've already did half of that. We got the other half. It's basically
was that because, again, there were some times there where they offered us additional.
What happens is a lot of the cost reports, the federal government or the state overall in their grants, and this is all hospitals basically because they come with a block grant. They're not actually all adjudicated for a couple of years. Okay, so when they're adjudicated for a couple of years and the state's actually been paid more than their cost during all this process in the interim, meaning interim rates, interim settlements, et cetera, then they have to allocate out what everybody has to pay back. You think ours is high, the rest of these big hospitals, what they're having to pay back, and it's in the millions.
Oh, huge. Right, huge.
Okay, so that's what it is.
How much was it?
Oh my gosh.
What
I
was
don't know.
It was
I don't know.
almost 400,000.
Small part
it?
is probably.
It was almost 400,000.
Okay, well, that's not bad compared to what
Yeah.
we're getting.
There are a lot of noise coming from the classroom there because
There-
this might really get overrun.
They have orientation this morning.
Yeah, it's really noisy.
Yeah, we're almost done, right, Chet?
Yeah.
Anyway, that's my report, and I'll turn it back to Barbara. Unless you have questions.
You started talking about the pharmacy on page, what was it, 18? Or whatever
18?
page. Yeah, oh, wait a minute. Where was
That's page 28.
28? And then Tim interrupted you and you forgot about pharmacy.
You're pointing at me.
Sorry, it sounds like they are having a class next door in that classroom. I asked them.
Now, the rate, you're talking about 18 and the ratios?
Well, I'm talking
20
about the pharmacy losing money.
The
We need to work
Product
on the pharmacy. I just wanted
how's your product line?
yeah.
Okay.
Okay.
Okay, thank you. Chet, you're done?
Yes, I am. Barbara's turn again.
The next page is just the local vendor list. It asks to have where I am with payments to the local vendors at the
Now,
time
what
of the
page
meeting.
what page?
31. So the total outstanding right now is $12,000. Page 31.
I got 30 and a half.
Anybody have any questions? Do you have any questions?
No, these are all appropriate. I just want to make sure that Gary's goes through now because that has been signed. We have received a signed copy.
One thing on the water company, the water bill, Scott had offered, now I know this probably should be planning, but just real quick, Scott had offered to give us water from across the street. That's good water for landscaping and everything. It could be used for that, but much reduced price. So we should work on that.
Yeah, we've had some conversations with Scott about that. So it's in our work plan. Let's put it that way.
Okay. Okay, thank you.
You're welcome.
The next page is the list of contracts that come due within the next 90 days. But the managers are required to review any contracts that are coming up, get them renewed if we're going to continue using them. This is information for the board so that they know what contracts we are using. Abbott Laboratories is a service contract for the architect equipment in the lab. It really doesn't end until 2022. So we look at
this is not architectural fees, Gene. This is the equipment is named architect.
Whether or not they're coming due.
Okay.
So that everybody knows what contracts are on there.
Okay, thank you.
ADT is a service and it's actually paid by the auxiliary. They have alarms on the thrift shop. Adventist Health is just a purchasing agreement. There's no cost to that. It gives us discounts on using certain vendors to buy items.
Group purchasing agreement.
Yes. Dr. Carslin, Dr. Crawford, and Dr. Geem are all on here, and their contracts are in the packet. And so I'm assuming we'll discuss those later.
Okay.
Yeah, these are all for expired.
Yeah, basically it was just that it was time for their contracts to be renewed. Their contracts had run out. We only can go for 3 years. So their contracts basically are running out. And so what I did was I didn't really change any wording in the contract. I just changed the dates of coverage and updated for the cost of living, if you will. And that's really
I have a couple questions when we get to that. I'll share them with you. So, but yeah, otherwise it was good.
DK Golding is not something that we're using, but it's a service that we would contract for certain things. It's not something that we're using all the time. GE Healthcare is a service for equipment in X-ray. HPSI is a service that the dietary uses for online menus. Infinite Consulting is software support for storage, the way Carrie keeps our systems running. JWT, his letter is in the packet separately. We'll be discussing that later. Kern Health Systems.
Going to be discussing later today?
Yeah.
Okay.
Yeah, it's in the packet. Kern County Public Health Services is emergency response and the trailers that we have for surge and capacity resources. There's no cost to that. Lake Isabella storage is rental units. We have 4 units that we rent for storage at $75 a month.
Will we be, Tim, are we still gonna need storage units? Shouldn't we?
Yeah, some of this stuff is like for old beds and things like that, that they use for parts and things like that, that we wouldn't want to put in that building. We have reduced the number of units that we have. I think I'm still pressing them to go in and see if there's some opportunities to get rid of some more. I think the one had some records in it, if I'm not mistaken. So.
And we still, you know, we're gonna have a situation also as we move into the new buildings. We may need some room there again. So we kind of want to keep that available until we get the moves done.
Right, then we can reassess.
Medical recruitment strategies is a medical staffing registry, only used as needed. One staff medical is a nurse registry, it's only used as needed. Philips is a service agreement for the ultrasound. And Philips has another agreement for the echo, and that's to provide service and backup support. Praxair is the rental on the O2 cylinders, various rates depending upon the types of units they're using. ReadyLink is also a nurse staffing.
Do we get prices on this like
Yes, but the
Praxair?
cylinders are different prices.
Because there's different sizes.
Right.
Is your question, Gene, do we go out and shop that for reduced prices? Is that what you're asking?
Yes.
Also, we try to change to concentrators where they don't have to have as much as we can, but there's some things both in maintenance and for the patients that we do that can't be liquid oxygen out of the big tank or a concentrator. And so those things we still have to get cylinders for.
Okay, thank you.
ReadyLink is a registry also, and Sparkle, they do the mats and some of the other laundry things regularly, the cleaning. And then we had old agreements that Dr. Finstead, I believe his is in the packet also. And then Alta Sierra Broadcasting.
Dr. Finstad's was the old one that he hadn't signed yet.
Yeah.
But I got it signed since then.
Oh, okay.
He did
This
sign
can
it.
come
Yes,
off.
he did.
So that can come off the list, yeah.
And broadcasting, we were gonna go ahead and ratify it or continue on. I think
We have basically,
Provided us with the proposal, but it was after the finance packet was already out, and so it's gonna have to go next month.
Okay. It's
But it's in
all
process.
right, the way it is, okay.
And that's all the contracts. Jump over Grace and Carrie. And the auditor's engagement letter is the next item on the agenda.
Which page is that?
It's gonna be 55.
And Chet's going to talk about it.
Yeah, I am. If we're there, I will. As you saw on the contract listing, it's time for us to send out some requests for our audit for 2021. I've been extremely pleased, continue to be extremely pleased with JWT. Their audit is timely, it's thorough, it's accepted by the state. I've tried other units or other providers, and they either don't do it, or if they do it, they want to charge us twice the price. Or and even then, they send their juniors. We have to do most of the work, and they're never ready on time.
right.
So I would like to ask JWT to send us another engagement letter for 2021, and that's what this letter does. Is that it asks for it tells them what we want, and to send us their engagement letter to review.
And now last year, the price was quite a bit less that they contracted for.
There's no question that the contract is better to stay with them. It's probably for example, I got a bid last year. I tried 4, and I only got a bid from 2. Moss Adams was the other bidder, and where we were paying 30,000 or so, their bid was like over $100,000.
Yeah.
They might have saved us a lot of money.
Yeah.
I'm kidding. Okay, she's gonna be good with me, but, okay. Do we need to do anything on this?
We need to
Go
send
to
it to the
consent
board.
or anything?
Send it to the board.
Well,
Okay.
again, this really here is just, you're waiting for the proposal to come back in, because
Okay.
we'll have to approve that one.
Okay.
Yeah, it's just a request for proposal is what it is.
Okay,
Nothing to approve.
Can we back up for a second, though? On the list of contracts, were there any questions? Can all those go to consent then?
yes.
Okay.
Okay, thank you.
Dr. Carson's agreement is next.
Okay, let's just keep it simple again. Chet has adjusted all 3 of these contracts for Dr. Carsland, Dr. Geem, and Dr. Crawford. He adjusted the rates on these to $65 per visit. There was a standby fee of $55. The only question I had on these was that under Dr. Carsland's contract, there was a minimum hourly rate of $110 an hour. Geem's contract had a minimum hourly rate of $140, and Crawford's had a minimum hourly rate of $120. Dr. Geem's and Dr. Crawford also had a ease of scheduling stipend on there, but that we didn't put into Carsland. So I was just wondering if we could go back and adjust those all to the same minimum hourly rate with the.
We can, but I recommend we don't. These contracts have pretty much been individually negotiated in the past.
Yeah.
Doctors come in and he said, it's not enough for me. I want to do this. Okay. That's the reason why there's those differences. For example, with Dr. Carsland, he will pick up shifts, but he usually doesn't pick up more than the 6. Okay. He has less. And then what he does is pick them up when Marie offers him something, then he'll pick up a shift. So it's kind of based upon.
Well, the whole point was the ease of scheduling thing was to act as an incentive to pick up more shifts. So if he doesn't have it in his contract, then maybe he would take on more shifts. Because I know he had 8 in December. I went back to look.
Actually, but he might not. But he may not. So the situation is what she offers is it's actually where it falls into play that she can't schedule it. Where he's going to pick up more shifts is where he's actually scheduled if you pay him more in the contract.
He only had 8 in December because he was covering for ill physicians.
Oh, is that what it was?
Yeah.
All right. I just, again, the point is we put it in. I just felt that, hey, because he seems to be.
Dr. Chalmers in here, it'd be 3 times that, because that's what we've negotiated with him. So
I understand that. I was just, like I said, I was looking at that and it just kind of struck me as, we have it in the other 2 contracts. I thought, maybe, hey, this is an opportunity because Carsland, like I said, has been willing to pick up more shifts when those bonuses were offered. But so maybe if there was the ease of scheduling, that maybe he might be interested in, might be incentivized to take on more shifts.
The problem is, though, he might schedule the shifts and he won't pick them up. See, he doesn't get paid anymore if he picks them up.
That's unusual for him. I mean, he's usually pretty darn good about covering the shifts he gets. So he's not the one I worry about from canceling or things like that.
But it seems to be working, at least right now, it seems to be working well. I think we would have to do this if we're either getting complaints from physicians or we had a situation where we couldn't fill shifts and we're having to go to registry. Neither of those things are happening. Even when they pull out in the middle of the month, we're being able to.
No, I get it. I get it. We've been
really
very good. Yeah, we have. I do agree with that.
So if anything, we have more hours than we need. On the other hand, a lot of those hours are coming from Dr. Newell. And so the question becomes, should we be giving him as many hours as we are? That's been cutting down a little bit.
Yeah.
So I don't have an answer except it's working.
Yeah, no, I hear you. And like I said, you have adjusted the hour, the actual rates and stuff like that. So I'm okay, I guess, with leaving it the way it is. If there's an issue that they have a question on, because like I said, these will have to go back and we'll adjust these because these haven't been presented to them yet.
Yes.
But I'm okay with that. So, all right. I'm good.
Okay, so are there any questions on the contracts?
But the way it is right now with COVID, there's not many patients going through there.
Right.
They're sort of sitting around. Could we have them do something else?
See, that's the other thing when you change it on the contracts. Right now, we're seeing less than double digit a lot of time in the ER. Meaning
Yeah, no, I get you.
7 patients, 9 patients, 8 patients. Well, you got to pay the doctor the same minimum, no matter whether he's 3 patients or none.
Yeah, I hear you. I hear you. It was interesting. I did notice going back when Barb was doing the statistics that where we were down dramatically, I think it was like 300 plus of visits in the ED was urgent care. The urgent care numbers dropped significantly from last year. So on a year-to-date basis. So we have seen a cut there, which is what we were anticipating with COVID. We're seeing more of that going to the doctor's offices. And that was something I've heard from the other CEOs as well.
I will tell you, for example, I do need to bring. I'm sorry, go ahead, Mark.
We're seeing is patients are staying in the ER longer. They're experiencing 20 and 30 hours in the ER because we can't transfer them out. And all of that time is spent for the doctor taking care of those patients.
So even though we've had fewer patients, it's much more intensive care.
The intensity of service is higher.
Yeah.
Now, are some of those patients taken care of by Dr. Gross?
Only if they had been admitted and sent back. The ones that are sitting in the ER waiting for transfer are being taken care of by the ER physician.
Okay. And when are they actually, if they spend the time, were you actually putting a higher level in there, like observation level in the ER?
Can't answer that. I think that they're still treating them. They haven't switched them over to an observation status in that light.
That's the question.
Okay.
Because if they're there a long time, you have that base rate, whether they're initially for the ER. And so the question becomes, if you have to spend more time with them, shouldn't you be increasing that? That's all I'm asking.
Well, all I'm saying is that those patients are a higher level of care transfer. Do they warrant an observation status or not? I don't think so.
Yeah, you don't think so?
No, because they're being maintained, but we're not providing the scope of service they need. They need a higher level of care, maybe a surgical consult.
I don't disagree with that, but the question then becomes, we still have the concern is you still have the nurses and the doctors providing the hours.
Yes. I don't know what the answer is in this particular environment, especially with the pandemic and COVID and overcrowding in ERs.
I don't have the answer either, except that my recommendation would be, if you're having to have care and even though it's maybe the same care, I mean, your ER visit shouldn't be more than 90 minutes. I'll pick up something there.
Okay.
And if they're 30 hours, you really need to have them in observation.
There is an observation charge. I don't know if it's going on those, but the patients that are staying longer in ER should have the level charge and then an additional obs for the extended time.
Yeah, but that max charge, Barb, is I know there's like a max visit, a level 5 visit and stuff like that. But the question is, if they're in there for 20, 30 hours, there's not an hourly charge on top, is there?
Yes, there is, but I'd have to go look and see if that's getting applied.
Well, we certainly have to have a discussion about it to figure out what's the best course of action, because right now, I don't think that status is being changed because of the way we do things here. If somebody's admitted to observation, our facility historically sends them out to the floor to be taken care of by Dr. Gross or the hospitalist group. And so I think that's where we'd run into a little bit of a problem.
So that could be a loss. That could be a loss for us, Chet, for COVID, because a lot of that is what's tying us up. And so we're losing money by not being able to charge or whatever, by tying up the emergency room.
The
I'm
other,
looking at the PPP.
remember, getting ready for the future. It's hard to change people's process or plans, but the situation is we have to think differently. I've tried to say observation days are not included. I get the pushback, oh yes, but they're not laying in the bed. Well, they really want what the system really wants itself is that observations are never inpatients.
Okay.
Right.
The easy way to do that is to have an observation unit that's tied to the ER. We're going to try to do that.
Yeah.
And they need to get used to that.
Well, I get
We're
it.
going to have 15
I hear
beds.
you. I hear what you're saying. Does the hospitalist group manage those OBS patients then at that point?
Not usually,
Yeah.
but they can.
Yes.
Well, we'll
The
have
other
to have some discussions about that.
Can we go back, check and see how we're getting paid on some of these long-term cases that are ending up in the ER? I'd
Well,
certainly
really,
love to see.
If we're only charging regular rate, that's all they're going to get, Tim.
Yeah, I know. That's what I'm
Not even
concerned
doing
about.
observation.
Right. I know. Wow, you're providing almost an intensive level of care, in that unit. I'm just
It's not
curious to
just-
see how the
Not just the intensity of service, it's the length of time as well.
Right.
right.
Absolutely.
Exactly. Understood.
And yeah, and we're using massive resources on a lot of those patients.
Right.
Yeah, we are.
So we should be able to figure out a way and with our PPP money, show that as a loss, Jet, at worst, because we get every penny of it back. You know what I'm saying? We're providing a service we're not actually billing or being able to bill for, but we're still having a loss.
Yeah.
So, but at any rate.
Chet and I are looking actually at the possibility of refiling on the second round of PPP. He and I just had some conversations yesterday about that. So we're looking at.
I got a call from the bank while I was on this call. I'll have to call them back.
Okay, good. From West America.
Yeah. You're closing up. One thing, Barbara or Chet, I've been here on this board for 2 years. I haven't seen a propane contract come up. Do we have a contract or do we shop it? What do we do?
Propane,
With who?
Yeah.
propane we shop every time every year, almost, Barbara, right?
Well, I've never
No, they
seen it
haven't
come
done
up.
it. They haven't done a contract with a propane in a long time.
How do
The
you
limited-
shop for it?
Well, the biggest issue is filling the large tank, and not all of them here can fill that tank. And so we're kind of limited and locked into using a certain propane.
Yeah, one of them was going to take like 3 or 4 runs to fill that tank up, if I remember correctly. It's pretty.
Because in the summertime, you can get like $1.40 a gallon. And
Yeah.
are we paying more than that?
I don't know.
Well, how can we find out?
I can look.
Bob Easterday knows. Yeah,
I'd like to see what we're paying because,
sure, not a problem.
okay, is that it? Okay, do I adjourn the meeting?
You do.
Tim, does anyone have anything else?
Yeah. I'm good.
Okay, meeting's adjourned. Thank you so much, Chet and
Thanks, you
Barbara.
guys.
You guys are awesome. Tim's not bad either.
You too, Gene, no matter what they say.